So the budget recommendation for fiscal year 25 that's in House Bill 1 is $19.8 billion for the Department of Health. On the left, you can see that $14 billion is from federal funds, $3.1 billion is state general funds, $1.3 billion is statutory dedications. There are 8,281 authorized positions within the department. And on the right, you can see that Medicaid is $17.9 billion, which is almost 91% of the budget. LDH is split up administratively into two different areas. You have your LDH agencies on the left. This includes the Medicaid agencies. And then on the right is the Human Service Districts and Authorities, which are the local government entities that act independently from LDH and from each other. The mission of LDH is to protect, promote health and to ensure access to medical, preventative, rehabilitative services for all citizens within Louisiana. LDH is one of the few departments that has a preamble within House Bill 1 that provides additional guidance. The preamble allows them to pool cash between budget units within the department. They're able to carry over collected funds from prior year from any budget unit as long as it's used for Medicaid. They can transfer up to 25 positions at a time and the associated funding between agencies within the department without JLCB approval, and the max of 100 positions and $6 million within the year. Here we have the historical 5-year spending. The average annual change from fiscal year 19 to fiscal year 23 is 8.6%, and the majority of the increase is due to the influx of federal funds related to the public health emergency between fiscal year 20 and 23. And you can see that the budget is decreasing in 25, and that's because of the federal funds that are going away. Here we have looking at the beginning budget versus the final budget, and the area in gold is the actual spending. For fiscal year 23, the unspent budget authority was 8.5%. The main sources of funding are federal funds, the majority being from the Medicaid program. But the department also receives federal funds from Community Mental Health Services block grants, Substance Abuse Prevention and Treatment block grants for the Office of Behavioral Health, and then from the WIC programs and the STD and AIDS prevention programs within the Office of Public Health. The department also receives $3.1 billion from the State General Fund, $1.3 billion from statutory dedications, and we'll go through those in a later slide. And then they receive $700 million in interagency transfers and $644 million in self-generated revenues. So here is next two slides breaks out the statutory dedications. I'm going to highlight some of those. So the first one is the Medical Assistance Trust Fund, or MADF. You can see that the appropriation for this fund is decreasing by $210 million in fiscal year 25. This is based off of REC projections. This fund collects provider fees, and it also collects an annual tax based on the gross amount of receipts of premiums paid by the Medicaid enrolled managed care organizations, and then uses those funds to draw down federal funds. And we're going to see this come up when we get to the Medicaid of some of the means of finance and swaps, because the collections in that fund are going down. The next fund listed is the Hospital Stabilization Fund. This collects funds based on the hospital assessments on hospitals throughout the state, and it's based on an annual resolution passed by the legislature for fiscal year 24. It's HCR 3. Rural hospitals are exempt from this assessment. The funds that are collected are used to maximize the federal reimbursement, and they're paid back to the hospitals by hospital direct payment reimbursement enhancements. The third fund listed is the NOW Fund, or the New Opportunities Waiver Fund. This fund collects 12% of the excess over the REC forecast. The funds can be used for any home community-based service waivers for citizens with developmental disabilities. On the next slide, the first one listed is the CAL Fund, or the Community Options Waiver Fund. This one also collects 12% of excess over the REC forecast, and it's used for waivers for individuals with adult onset disabilities. Here we have the overall funding changes for LDH. You can see that the State General Fund is increasing by $200 million. This is primarily due to means of financing swaps within the Medicaid program to replace the MANA funds, and then to replace federal funds with State General funds. All other means of finances are decreasing significantly, and we'll talk more about that as we go through the different agencies, and they're primarily due to Medicaid because of the disenrollment of the public health emergency. This lists out all of the agencies within the State General Fund, with all the agencies within the department. you can see out of the $3.1 billion of state general fund, the medical vendor payments are $2.5 billion. That's the Medicaid payments. During this presentation, we are going to go through, Paige will do the Human Service Districts and Office of Behavioral Health, so we'll go through the 10 Human Service Districts and the Office of Behavioral Health. We'll also go through Office of Public Health and Office of Citizens with Developmental Disabilities, and then Medicaid. The remaining ones we're not going to go through during this presentation. The information is provided in the back of the presentation. If you have questions, the department can answer those for you. So here's the total funding of all agencies. So out of the $19.8 billion, $17.3 billion is from the Medicaid vendor payments. This is looking at LDH compared to the state. LDH receives 41% of the total state budget, and then 26% of state general funds. Medicaid is 37% of the state budget and 22% of the state general fund. Then expenditure recommendations. Other charges are 91% of the expenses within the department. We'll show a breakdown in a few minutes of what's in other charges, but it is primarily the Medicaid vendor payments. Now we're looking at the expenditure comparison from fiscal year 24 to fiscal year 25. The expenses are decreasing by a total of $1.7 billion. We'll see more details of this as we go through each agency, but it is, again, primarily due for Medicaid due to the disenrollment. Here we have the other charges and the interagency transfers. The largest expense in the other charges is the Medicaid vendor payments, which is almost $17 billion. $15.8 billion of that is payments to private providers. This includes the per member per month payments to the MCOs, the behavioral health partnerships, and the dental benefit plan. You'll also notice that $257 million goes towards the Office of Public Health for the administration of various grants, $208 million towards the personnel costs and operating costs for the human service districts. On the right, we have the interagency transfers. LDH transfers $349 million of Medicaid vendor payments to agencies within the department, $252 million to OTS. Out of the $3.1 billion of state general fund, $1.9 billion is non-discretionary, meaning it's harder to cut. $1.2 billion are discretionary funds. Now we see the total positions. As of January 29th, there were 593 vacancies within the department. On the right, we have the historical average salary. You can see that LDH has historically been on trend with the statewide average salary. At the bottom, we're looking at the positions compared to salaries. Here we have the turnover history. We can see that in the last 3 years, LDH's turnover has risen and is now higher than the statewide turnover. And on the right is the top positions that were vacated in fiscal year 23. The residential service specialists 1 and 2 are the top, followed by the correctional guard. I'm going to now turn it over to Paige. She is going to go through the human service districts and the Office of Behavioral Health.
My name is Paige Filliard with the House Fiscal Division. And here you will see an overview of the overall function of the districts and authorities, which primarily focuses on providing community-based treatment. And then on the right, you will see their locations around the state. The total budget to be received by all human service districts and authorities is $231.5 million. This funding primarily is in state general fund at $141.2 million, or 61% of their budget. There is also a breakdown of each expenditure category below, in which you will see that 95.9% of charges are in other charges at $221.9 million. On the next slide, you'll see a historical spending of the agencies. The overall budget has risen 5.2% from 2019 to 2023, with the largest percent change being in federal funds at 46.4%. But the most noticeable change on the graph is the interagency transfers with a 17.9% change. On this slide, you will see the funding comparison of FY23 actual expenditures, FY24 existing operating budget, and FY25 HB1, with the most notable changes being from FY24 to FY25 being a $3.7 million increase in state general fund for standard statewide adjustments and a $1 million increase in federal funding for a new grant in the Florida Parishes Human Service Authority. The next slide shows the expenditure comparison of FY23 actual expenditures, FY24 EOB, and FY25 HB1, with the most notable change being in other charges at $3.6 million due to statewide adjustments and certified community health clinic substance abuse and mental health services administration for the Florida parishes, which is, again, that grant that they received and federal funds. Moving on to the Office of Behavioral Health. There are two programs within the Office of Behavioral Health, being the Administrative Community Oversight and the Hospital-Based Treatment. The total budget to be received by the Office of Behavioral Health is $436.5 million. The major means of financing are as follows: $162.1 million in interagency transfers, or 37.1% of the budget, $161.8 million in state general fund, or again 37.1% of the budget, $104.5 in federal funding, or 23.9% of the budget. There's also a breakdown of each expenditure category below, in which you'll see major expenditure categories are salaries at 25.9%, or $112.9 million, other charges at $109 million, or 25%, and interagency transfers at $87.7 million, or 20.1%. On slide 31, you'll see the historical spending graph for the Office of Behavioral Health. The overall budget has risen 8.4%, with the largest percent change being in federal funds at 18.4%. Here you'll see the funding comparison, and the most noticeable change here you'll see is an $18.5 million increase in state general fund for additional forensic beds, a contract increase, and dietary increases, and a $7.2 million increase in interagency transfers for standard statewide adjustments and rising pharmaceutical costs. And then on this slide, you will see the expenditure comparison for the agency. You'll see in personnel services, they have a $4.7 million increase due to standard statewide adjustments. And now back to Julie.
All right, next up is the Office of Public Health. This is the second largest agency in LDH. The funding recommendation for fiscal year 25 is $774 million, and 71% of that is federal funds. At the bottom, you can see that the other charges makes up about 66% of the expenses, and then salaries and other compensation-related benefits make about 18% of the expenditures. The mission of this office is to protect and promote the health and wellness of all individuals and communities within Louisiana. They do this by monitoring the food, keeping water safe to drink, fighting chronic communicable diseases, manage, analyze, and disseminate public health data, ensure access to public health records, and other preventative health services. Here we have the average, the historical 5-year historical spending. The average annual change from fiscal year 19 to fiscal year 23 is 12.8%. You can see the steep increase in fiscal year 22 followed by a steep decrease. This was due to funds received from GOSEP and for FEMA reimbursement during the public health emergency. The funding comparison, there's an $89 million reduction from fiscal year 24 to 25. $88.5 million is in federal funding. $80 million is from COVID-19 grants that are going away. $8 million is from a fiscal year 24 line item appropriation for a program to address health equality and improvements in health in rural and underserved communities. Now we are looking at the changes in expenses from fiscal year 24 to 25. The majority of the decreases are due to the federal grants related to the COVID activities that are going away. Up next is the Office for Citizens with Developmental Disabilities. The proposed fiscal year 25 budget is $219.9 million. 75% of that is from interagency transfers, and 20% is from state general fund. At the bottom, you can see the expenditures. Personnel services are 66% of the total budget, and other charges are 12%. OCDD is a single point of entry into the developmental disability system and oversees public and private residential services for people with developmental disabilities. They oversee several waiver programs, the Early Steps program. They handle legacy costs for the privatized developmental disability facilities. The agency also houses 2 facilities, the Pinecrest Supports and Service Center in Pineville and the Central Louisiana Supports and Service Center in Alexandria. The historical spending. The average annual spending change from fiscal year 19 to fiscal year 23 is 6.2%. This is comparing the fiscal year 24 to 25 funding. There's a $621,000 decrease. In state general fund, the increase is $553,000, and this is for employee pay raises, group benefit insurance related benefits, and it's offset by the attrition adjustment and the savings from the retirement adjustment. There's a $1.3 million increase in interagency transfers due to the increase for employee pay raises, increase for dietary food service contracts, and remote technology and virtual visits. This is offset by a decrease of fiscal year 23 funds that were carried into fiscal year 24 that won't be needed for fiscal year 25, and also the retirement and attrition adjustments. There's a $124,000 increase in fees and self-generated revenues, which are a means of financing swap to replace funds transferred from Medicaid with ineligible patient fees. Now looking at the expenditure comparison for fiscal year 24 to 25, the net decrease is $621,000. There's a $1.9 million decrease in personnel services, a $986,000 increase in operating services for increased cost of dietary services, $703,000 increase for other charges for a memorandum of understanding between OCDD and Medicaid to provide specialized treatment and recovery team model assessments, and then a $759,000 decrease for funding for acquisitions that are no longer needed. Now we're getting into Medicaid. So this is the last stretch. This is the big part. So the funding recommendation for Medicaid is $17.9 billion. Over 74% of that comes from federal funds, and at the bottom you can see that 95% of the expenditures are other charges. This is payments to the MCOs, public hospitals, Medicare premiums and, for dual-enrolled individuals, and public-private partnership hospitals. So Medicaid budget is comprised of 2 budget units. You have the Medical Vendor Administration and then the Medical Vendor Payments. Together they make up the Bureau of Health Services Financing, or known as what's known as Louisiana's Medicaid. The Medical Vendor Administration houses the Medicaid staff that determines eligibility, sets rates, looks at claims data, tracks the MCO compliance, and investigates Medicaid fraud. The Medicaid Vendor Payments is the budget unit that makes the payment for the services and what most people think of when they think of Medicaid. The average annual spending change is from fiscal year 19 to fiscal year 23 is 8.6%. The increase from 20 to 23 is due to the influx of federal funds from the public health emergency, and you can see that the budget is decreasing in 25, and that's because those funds are going away. Now we're going to look at the Medical Vendor Administration. The funding recommendation from them is $596 million, or 77% of that is from federal funds. At the bottom, you can see that IAT is the largest spending category, and this is transferred to other state agencies and agencies within the department. The funding comparison, the change from fiscal year 24 to 25 is a $170 million decrease. State general funds are decreasing by $50.5 million. This is primarily due to funding that was transferred from the medical vendor payments to the Medical Vendor Administration in fiscal year 24 that's no longer needed, and that funding was used for the disenrollment activities associated with the public health emergency, and that was for like the outreach and the advertising for the disenrollment. $27.5 million decrease in interagency transfers is due to funds that were carried forward in 24. The Medical Vendor Administration had contracts with OTS and other entities for deliverables that were not yet completed by the end of the year. And then federal funds are decreasing by $92.2 million. $55 million of that is for funds that were carried into 24, and then $44 million is for the disenrollment activities in 24 that the funding is no longer needed, or that the transfer is not going to happen. So now we're looking at the expenditure comparison within the Medical Vendor Administration. There's a $7.9 million decrease in personnel services due to employee pay raises, increases in related benefits and group insurance. This slide explains it. Increases in related benefits and group insurance. These are offset by decreases in attrition adjustment, retirement adjustment, and one-time personnel costs with the public health unwinding. There's a $29.2 million decrease in operating services, and that's mainly due to the expenditures related to the unwinding of the public health emergency. Other charges is decreasing by $128.1 million. $8.5 million decrease for the ending of the electronic health record program in fiscal year '24. There's a $10.2 million decrease for expenses related to the public health emergency, and $94.5 million decrease related to the fiscal year 23 funds that were carried into fiscal year '24. Now we have the recommendation for the medical vendor payments. $17.3 billion, which is $17.3 billion. 74% of that is federal funds. At the bottom, we can see that 98% of the expenditures are other charges, and that is the Medicaid payments that go out. Here we have the different sources of funding. Interagency transfers come from DCFS for the Behavioral Health Partnership, LSU to use as a match for the support of the LSU upper payment limit, which is a supplemental payment for the LSU hospitals. Various state agencies for state match for the Low Income and Needy Care Collaboration Agreement, and OGB for premium payments to collect it from the CHIP program. Self-generated revenues come from intergovernmental transfers and non-state public hospitals. Statutory dedications, this is the largest ones. It's MADF, the Hospital Stabilization Fund, the NOW Fund, Louisiana Fund, Health Excellence Fund, and then the federal funds, which are Medicaid. Here we can see the funding comparison. Fiscal year '24 to '25, the changes are primarily due to the end of the disenrollment of the end of the public health emergency and the disenrollment. In a couple slides, we'll have a line-by-line breakdown of the adjustments that make up this $1.4 billion decrease. This explains it, but I'm going to wait till we get to the slide that has the line-by-line breakdown because it's easier to see and easier to explain exactly how these adjustments hit each means of financing. And then this table explains the change in expenditures. The expenses are going down by $1.4 billion. So the $1.3 billion is, again, a decrease in the managed care organization program, which is consists of the utilization decrease, the rebate adjustment, and the projected enrollment decrease. And then there's a $1.7 million increase due to the increase in payments of public providers because of from the uncompensated care. All right, so this table better explains the Medicaid adjustments, and we can go line by line. The lines highlighted in gold has their own slides because there's a bunch built into those. So I'll start with the second line because that first one has its own slide coming up next. So the annualization of the fiscal year '24 nursing home rebase and inflation adjustment, the total change in that is a $67.8 million increase. Is $21.7 million in state general fund, $46 million in federal funds. And this is the Medicaid state plan allows for rebase every other year in an inflation year on non-rebase years. So every year there's an adjustment for the nursing home rebase. That second line is an $89.2 million adjustment. That's for the one-time transfer back from the MVA, from the Medical Vendor Administration for the public outreach for the unwinding. And it was split 50-50 between state and federal funds. And then if we go down two lines, the clawbacks, there's a $28.4 million for clawback payments to CMS. Clawback payments are paid to CMS for a portion of the Medicare drug expenses for individuals who are dual enrolled in Medicare and Medicaid. And then that is state general funds, so it's an increase in state general funds for those clawback payments. Next, we have an increase in budget authority for the upper payment limit to increase it up to what the current cap is. The current cap is $52.1 million, and the current funding level is $8.5 million. So this increases the federal budget authority so that they can draw down the entire current cap. Next, we have a reduction to remove one-time ARPA funding associated with the home and community-based services, and that's a reduction of $73.3 million in federal funds. Next, we have $12.8 million increase to provide funding for the federally mandated rate change for Medicare premiums and anticipating increase in the number of dual eligible low-income seniors and disabled individuals who qualify for both Medicaid and Medicare. And that's increase in state general fund by $4.1 million, and then federal funds by $8.7 million. The next is a $216.6 million decrease, and that was for carry forwards of fiscal year 23 funds that were carried into 24 that won't be needed for the upcoming year. So this is the means of financing swaps. So you see the bottom line is the state general fund is increasing by $242 million. So we can go through each one. So the first one is the FMAP rate change. FMAP is the federal medical assistance percentage, and that is the the match for the non-expansion group of Medicaid recipients. That percent is going up by 0.039% in fiscal year 25. So that equates to $58.5 million more in federal funds, and so it's reducing the state general fund interagency transfers and fees and self-generated revenue. The next line is replacing the enhanced FMAP and statutory dedications from MATIV. So the enhanced FMAP, during the public health emergency, we received an additional 6.2% of FMAP. The majority of that, it was phased out in fiscal year 24. The first quarter of fiscal year 24 was 2.5%, the second quarter, 1.5%. That's being phased out, so the federal funds are going down $110.7 million. And then the MATIF is not expected to collect as much, and so that is going down $174.4 million, and that's being replaced with state general funds. The next line is to replace funding from the Medicaid trust fund from the elderly that was used for the nursing home rebase. So when it was when the nursing home was rebased in fiscal year 24, they funded that with this Medicaid trust fund for the elderly, and this is replacing that. And then next we have the replacing state general fund with the Louisiana fund. So the Louisiana fund is expected to, the REC projections, it's going to collect more. So that's causing the need for the state general fund money to go down because that's going to collect more. And then the next line is kind of the opposite. It's replacing the Health Excellence Fund with state general fund. Based on REC projections, the Health Excellence Fund is expected to not to collect as much. So again, your bottom line is state general funds are going up. And interagency transfers, fees and self-generated stat debts, and federal funds are all going down. Here we have the managed care, the MCO adjustment. This is typically the largest adjustment in the state budget, and it's intended to capture the changes in rates charged to LDH by managed care companies. The first line is the enrollment adjustment. The projected enrollment in fiscal year 25 is expected to decrease by 51,000 participants. This adjustment also includes maternity kick payments, which are intended to cover prenatal care, delivery, postpartum care, and normal newborn hospital costs. Providers who deliver care to recipients are paid by the MCOs rather than directly by Medicaid. And then this also includes, that first line also includes annualization from the 24 disenrollment. So as people rolled off, they rolled off out throughout the year every month, they're rolling off, and so this is annualizing everybody that rolled off. So the net effect of that is state general fund is decreasing by $147 million, fees and self-generated $75 million, stat jet going down $44 million, and federal funds are going down almost $1.5 billion. The next line is the utilization rate. So this represents the cost trend adjustment for services covered under the Health in Louisiana. Utilization is increasing by 6.5% for the non-expansion group and 4.6% for the expansion group. And what this is as the disenrollment, people from the expansion group are coming off the enrollees that are left are participants that use their insurance more. So the utilization is going up is what that is. The rebate adjustment is drug rebates that are projected to decrease in 25. And then the net effect of that is $247 million decrease, $208 million in federal funds, $21 million decrease in state general funds. Here we have the managed care incentive payment adjustment. The managed care incentive payment program provides MCOs additional funds above their per member per month rate for meeting target stated in their contract. The enrollment and utilization changes the effects of the MCIP adjustment. So the expansion group is going down, but in this adjustment, the non-expansion group is going down where the expansion group is going up. The net effect is a $12.3 million decrease in federal funds and a $31.6 million decrease in state general funds for a total of $46.9 $5.9 million decrease. Here we have this is the federal medical assistance percentage map, the formula for that. So the blended FMAP rate in fiscal year 25 is 67.96%. This is the federal match on the non-expansion group. The federal match for the expansion group is 90%, and the federal match for the administrative cost is 50%. The graph at the bottom shows the increased funds that we received for the almost 4 years for the enhanced federal match, which that went away as of January 1st of 24. This is the roll-off of the enrollments from the roll-off. So from March of 2020 to March 2023, Louisiana could not disenroll anyone from Medicaid. Congress initiated the continuous enrollment coverage. The only way someone could lose their Medicaid coverage is if they moved out of state, if they died, or if they voluntarily disenrolled themselves. As of May of 23, there were 2.1 Medicaid recipients in Louisiana. During the months of June of 23 to January of 24, LDH determined eligibility on 64% of the Medicaid recipients. And it's not just their disenrollment, they had to determine eligibility on everybody that's on the rolls. 403,000 individuals were terminated because they were determined ineligible. And if you look at the donut chart, at the top right, the light purple and the green is what was disenrolled. That light purple is the disenrollment for no response, which is almost 271,000 people, and that represents about 67% of the disenrolled individuals were disenrolled for no response. Because of that, the churn rate is a factor. Churn is when people are disenrolled and then come back on or re-enrolled within 6 months. These numbers are as of January 31st. The churn rate is 30%, or I believe it's 116,000 people. About 50% of those were children that were, it's 119 people, which is 30%, and about 50% of those were the children group. This is showing the closures by category. About 50% of those that were disenrolled were from the expansion group, 31% of children, and about 10% of the age, blind, and disabled. Here we have the Medicaid enrollment trends as it relates to the population. And as of January 24, about 40% of the Louisiana residents were enrolled in Medicaid. And we can see here how the enrollment increased from 24 to 23, and it's now declining. That ends the presentation. Dr. Abraham and his executive staff are here, so I'm going to turn it over to them.
Well, that's a lot to talk about.
That's a whole lot to talk about. Well, good morning, Chairman McFarland and the committee. And I truly, sincerely mean when I say it is an honor to be sitting before you today. To my right and to my left and behind me, I've got my executive team, and what you're going to find that they are very well versed in their craft. They will answer your questions openly, honestly, and hopefully very precisely, because when we get into the detail, you're going to see this is a very, very complicated process of funding this. To the committee and to the general legislature, this is good and bad as far as the amount of funding. Y'all's ability to fund us has allowed LDH to treat, hopefully prevent, diseases, treat people that otherwise would not be able to access medical care. The very poor, those that are struggling with life. So in that aspect, that 41% of the state budget perhaps is a good thing. On the bad thing, we're not doing a very good job. Historically, with LDH, the money has not gone in many cases to where it needs to be. You've seen the stats. We've looked at them over and over ad nauseum. We're almost last in every category in Louisiana, whether it's obesity, maternal mortality, infant mortality, hypertension, congestive heart failure, you name it, we're not doing very well. We've got to do better. The governor and I have had extensive discussions, and I know many of you have with the governor too, that it's frustrating, and to me as a primary care physician, it's actually very angering that this amount of money is being spent and we're still in the bottom of the barrel as far as results. We have got to do better, and our task, our job, and our pledge is that with this money that you allow us to have, we will do a better job. Mental health was mentioned. It's a huge aspect of problems in Louisiana. You just saw the governor had a special on crime. Crime and mental health are often tied at the waist. We are failing those patients also in our mental health crises, where we're not providing the adequate care, evidently, that we should be doing, and that too has got to get better. At LDH, what we found in the few weeks that we've been on this job is that we've got some wonderful employees in the building. You saw we have 1,000 of employees. And talking to them, they know their job. Most of them know their answers. You just have to ask them the questions. Heretofore, they have not been asked. We are now asking those questions. And the money that y'all afford us at LDH, with this particular staff, with this particular team that I've got behind me, I promise will be used certainly in a very, very more effective area. Every one of us here in this building, we know somebody that has suffered some mental health crisis, whether it's drug addiction, you name it, we know it. And it touches every one of our lives. So that is a top priority for us at LDH. We will continue to have that as a top priority moving forward, and you will see that. I've been where you guys have been on that side of the dais, and your job is very, very tough. I've never had, and I'm sure you've never had, anybody come and ask you for less money. Everybody wants more, more, more. Well, hopefully we're not asking for that much more, and if we do, I assure you, we will tell you where it's going to be used and how it's going to be used and why it's going to be used. So we appreciate your work. We know you've got people pulling you in every direction that you can imagine. I don't envy your job. I've been there, and I know it's a tough, it's a lot of tough water to pull up the hill. So thanks for having us. We are open and ready and willing to answer your questions. Thank you, Mr. Chairman.
Is there anyone else wanting to make comments at the table before we begin? Okay, we'll go right into questions then. Representative Zarang for a question.
Thank you, Mr. Chairman. Secretary, thank you for taking this challenge on. Appreciate you. Appreciate your previous service. Just a couple questions. The roll-off and the unwinding effort, we put about 89, I think the department was going to utilize $89 million, what they said. Have y'all utilized all the money for the unwinding?
Actually, all of the money, I think you turned it.
Okay.
I think I'm on now, right? Closer. Okay. On the unwind monies of 89, actually, we have about a year. April is a year that has been in place. And of that, we have not renewed contracts. We've actually ended contracts that we did not think were needed. So we ended up canceling a little over $6 million of that and being able to then get that money back on a 50-50 match in terms of LDH. But we're still doing the key things in terms of going to people's homes and doing that kind of contact to ensure, as we'll share, and as you saw, the number of people who are coming off, but basically we're not having contact with. But we still spent about 82 of that.
82, okay, so you have 6 million that you've canceled contracts for.
Yeah.
Okay, in last year, the legislature appropriated 17 million to the, for mental health funding for education. And there was a BA7, I think, back in August to reallocate those dollars for utilization. I don't think the money has been used to date and has to be exhausted or utilized by June. Is there a plan to do that? And this was going to higher education, universities for behavioral health services. And as the secretary indicated, behavioral health is a critical issue. And just wondering where those dollars are and are they going to be utilized by the universities?
Yes, sir. Dr. Pete Grogan, I'm the Deputy Secretary, Interim State Health Officer. I think there were some challenges with the contracting process in terms of getting those off the ground when we came into office, but that's something that we jumped on pretty immediately to make sure that we spend those, because this is a huge priority and we don't have time. We treat this like a mental health crisis and emergency, and we don't have time to be bogged down by contract and paperwork in this space. So we want to do it right. We've put that into overdrive. I've got my team here that can talk a little more about the details, but we want to make sure we get that spent in time.
Right, and I fully appreciate y'all inherited this issue and y'all just new to the office. But if the money has to be utilized by by June, the end of June, is the intent to either extend the program, reallocate it, reapportion the dollars? Where are we with that?
I think our preference would be to spend it in time, but
Okay.
we want to make sure we use that money and it doesn't go to waste.
Okay, so the intent is to utilize those dollars?
Yes, sir.
Good deal. Thank you, Mr. Chairman.
Thank you. Representative Amade.
Thank you, Mr. Chair. Good morning.
Good morning.
Thank you for your opening comments. It's very encouraging,
Thank you.
Dr. Abraham. I had a few specific questions about the presentation, but for you specifically, I think I'll start here. What we just heard near the end of the presentation was about, let me scroll to the exact screen here. From pages 63, 64, and 65. Okay. Of the people who are rolling off, it's my understanding that the chart on page 63 is showing those who have rolled off and those who have automatically renewed. And the chart on page 64 says Medicaid closures by category. And we're seeing what seem to be the most vulnerable population here: children, the aged, blind, disabled, pregnant women. So were these truly no longer eligible? I mean, why did these roll off? These seem to be the people you're trying to help.
I agree, and I'll defer some of the comments, but I'll speak first. For us, it's frustrating because we are sending out letters and emails, and by law, we have to have at least 2 sources to contact these patients with, and I'll use that word patients as a physician.
That's fine.
The mail's not being returned, they're not being answered. And Michael and I were talking this morning, we're in one of these slides I was watching as a presentation has it on there. I think it was 270,000 people aren't re-enrolled because we can't contact them. Now, the question then is why? Well, are they not answering the mail, not answering the email? Have they moved? Have their phones changed? Yeah, all of the above. But to your point, bro, yeah, absolutely, this is our most vulnerable population, and if they qualify, we want them on the rolls. We want to help these people, but when we can't reach them, it's maddening, actually. Michael, you want to add anything to that?
I would like to add to that. I think part of it is, and I was talking with Kim, our leader in terms of Medicaid, is that for the last several years during the PHE, they were automatically renewed, the expansion group. And this year, they're having to actually take a step. So out of that 270, and since I've been here January 8th, we've continued to see that grow to over actually now 300,000. Here's what we're doing in order to try to contact them. CMS requires basically 2 modes of communication. We actually do 3 in order to try to touch base with them. So we're doing the text, we're doing the mail. As Dr. Ralph said, I mean, we're getting return mail percentage now of about 13%. And of that population.
I'm sorry to interrupt. Does that mean the mail that's bouncing back to you?
Yes, they're not
Yes,
answering,
bouncing back.
they're not picking up the letter.
So they're not picking it up. We're doing the 2, but then we're also sending it to the MCOs for them to be able to do contact and follow-up as well. So we actually have 3 means of follow-up that we're doing in order to try to make that contact. And that is a very vulnerable group, as you said, in terms of just that communication when you look at the roll-off. But that is what we're doing in order to ensure that we provide every opportunity for folks to be able to churn or turn back in terms of enrolling again. But I think, as we said, I said earlier, a lot of it is this transition that we're in because of the PHE.
Right.
And then people just did not have to pay attention. They automatically were enrolled and rolled over from year to year.
Yes,
that's
and perhaps didn't make it an effort to keep you abreast of their current phone number or address or what have you. Are you able to possibly track them through use of the program? Like, even if they moved, if they're still seeing their doctor, there should be some record.
And that's where we work with the MCOs to be able to determine, because a lot of times when they are enrolling again, it's because they've gone for a medical situation, they realize they don't have coverage, and then we're able to work with them. And so that's where we coordinate with the MCOs to be able to get that information back and make sure they're being re-enrolled.
Right, right. So thank you for the explanation.
We're also going to do something different than has been done. The information that we've been utilizing in terms of data has been actually from the federal data bank. They are basically saying that we're going to have to pay for it, which we have not been able, had to before, especially during the PHE. But as we evaluated that, and again, having been here since January 8th, and as Dr. Ralph said, relying on the staff, that information has a very high error rate of the basic things we need. So we are actually going to be transitioning to Equifax to be able to have a much better reliability in terms of the data that we're getting that will then hopefully help us be able to do that follow-up and closure one way or another in terms of that enrollment. But we know that will help us in terms of the error rates we've been seeing on the information that we have.
Well, I'm glad you have a plan there, but let me try to reiterate what I just heard at the beginning of your statement. The federal government, okay, Medicaid is a federal program run by the state. The federal government has a database, which is mostly incorrect, and they're going to expect you to pay to use that database.
Correct.
Yes, but we have an option now, and we're not going to take that option.
Thank you.
We're going to use a different option.
We're not going to pay for bad data.
Thank you.
Right.
Thank you. That's good. That's our tax dollars, so I
Yes.
appreciate that.
Correct.
Let me go on while we're in this section of the presentation. Slide number 65, it says Medicaid enrollment. Can you clarify my understanding of this slide as the numbers on the right-hand side that are percentages? It says percent of state population. Does this mean that in July of 2023, which is the last line farthest to the right, does this mean 45% of the state population was enrolled in Medicaid?
Yes,
Wow.
I know, yeah.
Yeah, that's
When COVID, that emergency hit, it was phenomenal
yes,
of the amount of patients that came on the rolls.
right.
Yeah,
Yeah, I just wanted to put that into the record. 45% of the entire population of the state was enrolled at that time.
Correct.
That's
that's a lot.
a lot, yes.
A little over 2 million.
Yes. So I have a few questions from some other slides, and I'm happy to have you answer them unless one of the ladies would need to come back. So going to page 19, way back towards the beginning, I simply wanted to question a line here. Let me get to the right page. Okay. On slide number 19, it says, where does it say it? The box on the upper right-hand side, the second line says avoidance of court orders. Can you explain that? Avoidance of court orders cost us $459.2 million.
Got it, Michael?
What do we do to avoid court orders?
Nick?
Yeah, we can break that bucket down a little more. I think there's probably several aspects. There's the legal component, and then programmatic changes that we make to maintain compliance with certain DOJ agreements, and for instance, the Cooper Jackson settlement. So my understanding is this is sort of a mix of program and legal fees, but we can break that down for you.
Okay, I just wanted to clarify what it was.
Yeah,
Yeah.
we'll get legal to circle back with you, okay?
Anytime. On slide number 21, I see that the biggest turnover is in residential service specialist 1 and 2. Can you just briefly explain what does a residential service specialist do?
Go ahead. Yes, you-
This is primarily in our facilities, Pinecrest and Elms. Residential service specialist is one of our direct care providers in Pinecrest, and that's one of the hardest positions to fill. As you see the turnover rate of 119%. In the last couple of years, we've had some really robust local workforce outreach, which is partially why costs have gone up for Pinecrest, because we've got to find people to take care of some of our most vulnerable.
We're having to pay a lot of contract work because we're not able to match what the privates are offering the CNAs, the nurses, those people that actually do the hard work.
Right.
They're very much in demand, and unfortunately, our salary is capped somewhat as what we can offer.
Well, I just wanted to clarify here in a public setting that those are the hard jobs.
Those are the hard
the,
jobs,
the
yes.
direct care jobs.
Absolutely.
These are the actual face-to-face people who work with the patients or the clients on a daily
Yeah,
basis.
they are the heartbeat of the entire facility, but unfortunately, sometimes we can't compete with the private enterprises.
Understood. My next question, I don't have much left here. My next question is from slide number 37. Okay, on slide 37, $80 million COVID-19 grants. Let me find where it said that on the slide. Oh, bottom right-hand corner, under federal, $80 million in COVID-19 grants. Okay, so I just wanted to have clarified. These are the grants that provided the federal funding for the mandated activities, I assume, during the COVID-19 shutdowns. I wanted to ask, of those activities that were provided by these grants, are there things that have now become permanent activities that we now have to fund through our regular budget?
We could do that deeper analysis, not that I can think of offhand. I think actually what we used in a lot of cases the federal funds for were to tie in additional health screenings, so use the COVID dollars to do cancer screenings and work on some of our chronic disease issues. I can't think of anything that would be a state obligation, a state general fund coming from these federal dollars.
Yeah, I don't
Okay.
think they left us holding the bag on that, so.
Okay, that was the
Yeah,
point of the
I understand,
question.
right.
Yes, if they're removing, or if the grants have expired and run
Right.
out,
But sometimes
what are we left paying
Sometimes
for?
they do take our money, you'll find, and they still mandate us to do the work.
I've noticed.
We're in it, so,
Yeah.
yeah, good question.
Yep. Let's see, and my last question is from slide 58. And it's simply the section here that mentions clawbacks. It's right underneath the double brown lines. It says clawback payments to CMS for Medicaid drug expenditures for dual eligible individuals. I want to understand, the clawback is taking money from where and sending it to where? And I'm assuming that by dual eligible individuals, it just means that at some point in the records, there was a double charge, which was not necessary.
Dual eligible means Medicare and Medicaid.
Okay.
They have both. Michael, you want to address the clawback?
Yeah, and the clawback is having to do with pharmacy. and those kind of services. And actually, it goes back to the federal government. And we are looking at about 205 million in terms of that. And that has to do with, as Dr. Ralph said, those that are dual eligible in terms of Medicare and Medicaid.
Gotcha. Okay, that's what I wanted to understand. And I had a couple of questions coming from a community provider. What is the status of the $12 a day add-on and the accompanying requirements? This is about the DSP wage floor and direct care floors. They'd like to understand the add-on was, let's see, it says, we understood that the add-on would expire at the end of fiscal year 24, but we're not sure if that's still the plan.
That is, we met with the executive director of the group and the providers, Caroline, and there were two things that came out of that. One was the add-on and it ending. The key thing there we have to do, and we have finished, is looking at the cost reports to see how that's going to impact in terms of that continuation. We have finished that, and we're in the process of scheduling a meeting to follow up with them in terms of where that's going to be in the cost reports, and that whether it's going to end or not, and how that's going to be impacted. The other item that was key for them was that they wanted to have, and we agreed, a rate adjustment study done. And we have funds through the ARPA, which we agreed that we would be able to do. And we have submitted to CMS to be able to have those funds, to be able to do that rate study, to then be able to plan with them in terms of what resources we're going to need to provide for them. And we're waiting on CMS. We believe, we have all the faith that they'll support that, but we still don't have that written approval to be able to move that forward.
Okay, so you're expecting all this to be taken care of in time before the fiscal year turns
Yes.
over? Okay. What is the status of the approximately $28 million that was appropriated in fiscal year 2023's budget and distributed as supplemental payments to ICFs? They understood that the funding would recur in the budget moving forward, but they're not sure if that's still the plan.
And that is also part of that cost report discussion we're going to have with them on that 28 million as well as the $12 an hour.
Okay.
Because it has to be within that cost report.
Okay.
And as I said, we've completed that study and information, and we'll now be meeting with them to go through that.
All right. And the
Before the
last
end of the year.
question. Thank you. The last question is, the governor's executive budget included a request for a non-rebased year inflationary adjustment for ICF's $6.5 million total effort. Is that included in House Bill 1?
Yes, it is included.
Okay.
Yes, it is included. I
Thank
was
you.
looking at my team to confirm before I answer that.
Yeah, I was about to say, well, you might not know what's in House Bill 1. I might have to ask House Bill 1's author, but
Yeah.
thank you. Thank you for your question, your answers. I appreciate your time. That's all, Mr. Chair.
Thank you. Representative Marcel.
Thank you, and welcome to the committee. I have a couple of questions, and my questions are probably going to be centered mostly around mental health and addiction. You know, when you sat at the table, you said that you were going to make sure that the dollars that we provide in this budget would go to the best possible places. And so for me, one of those concerns is the lack of dollars that are going to mental health and addiction. You also said that you had asked employees questions, and they had not been asked those questions before. What can you reiterate on what you meant by that?
Yes.
Yeah.
I have been walking floor to floor, meeting the staff, and as was on the slides, a lot of us. But talking to them, they each have their speciality, their specialties. They're very good at it. And when I ask any specific question, I get a specific answer. If I ask a general question, I get a general answer, what doesn't answer the question. So knowing what question to ask and a little bit of, I guess, insight, I have a little bit of an advantage there is that I have, fortunately or unfortunately, dealt with this patient population almost my entire adult life. So I know what drugs cost. I know what it often costs to go into an emergency room as opposed to an inpatient or an outpatient facility to help these poor people, those that are struggling with mental and addiction issues. So when you find that employee that whose arena that is, they know that answer. But you have to ask that specific question. And I can tell you, they may rebut me to a point, but they haven't been asked heretofore. I have that ability that since I have the practical experiences on the physician side to ask that question. So it's been very rewarding and very eye-opening and very enlightening for me to know that those people in that building across the street, they know their business and they are wanting and willing to help. And with y'all's help with the money, we can move this needle from 50th up to where we need to be as a state, way higher than we are now.
Okay, so I just want to make sure I understood, get some clarity on what you meant by that, because, I mean, these people have been there for many, many years. I would assume that they've been doing whatever it is in the best interest of Louisiana while they
Absolutely
were
they
there.
have.
So I want to make sure we clear that up.
Right.
So LDH has both private and state-run mental health facilities, and it has been said in the past, I think, during some of our joint budget meetings, that the private facilities are less costly than the state-run facilities. Have you had an opportunity to look at that?
We have. Pete, I'll let you handle that.
And what are those?
Pete's our
What are those
public-
numbers? Can you tell me what the numbers are for the beds?
Okay.
Yeah, I can get you those numbers, but correct, there is a significant cost differences because of our state facilities functioning as the safety net services. So for patients that are typically higher cost, multiple comorbidities without alternative sites of care. But I can get you the cost differences.
I just want to know how many state-run facilities that we have and what's the cost versus the cost of a private bed.
In terms of total facilities, we have Elms as a state-run forensic psych hospital in Jackson. We have Central Hospital in the Alexandria region. We have Pinecrest also in Alexandria, and Villa in Jackson are four big ones, as well as Central Supports and Services in Pineville. Those are our five big facilities.
And I'm interested in knowing what the cost is versus in the private setting versus the state. And I would assume that the cost in the private sector is much lower.
I'm sorry, I didn't hear that
The
last.
cost in the private sector when we do the contracts, is it lower, much lower than the state beds?
If we're looking at extra beds, for instance, those are beds that are forensic in terms of community-based beds. If you look at the private, it is about half of what we would see at Elms. If you look at the inpatient side at Elms,
When you say half of what you'd see at AMS, are we talking about cost?
cost.
Okay,
Yes.
so
It's
half the cost.
Yes, it's about
Okay.
half for extra. When you look at the inpatient beds cost at Elms, that's running about 770 or so a day. That is very competitive with what you see actually in terms of the private sector as well. So we do see some difference on a few of the beds, but not when you look at the inpatient side. And if you look at, you have 160 beds at Villa, for instance, as well. That cost is about $471. That is very competitive in terms of what you're going to find in terms of the private sector as well.
Okay.
And that's about 160 beds. They run about 145. We're looking for them to run closer to that 155 or so in terms of that. And in terms of if you think about Elms, I mean, there you've got the forensic at 239 in terms of the number of beds, and 330 on the East Hospital. And then the secure, the extra beds is about 108 there. And then they have the ICF as well, and that's about 16 in terms of beds.
So the cost overall would be,
if you look at the cost overall, and we normally break it out by those categories of programs that we
Right.
just mentioned, that cost is anywhere from overall is about 630. If you look at East LA, it's about 531. If it's
So it
cost per day,
fluctuates.
I'm sorry.
It fluctuates
Yes.
depending on the type of bed.
Yes.
And the type of patient.
And the type of patient.
Right.
But if you look at just the average, the overall is 630. But again, we look at it by program. If you look at the ICFDD, for instance, that's 686, and the cost per day in terms of East Hospital is actually about 531.
Okay. And since we're on mental health, the providers haven't received a Medicaid rate adjustment since 2012. Are you aware of that?
We are aware.
We are aware.
And if we are serious about addressing mental health issues and we're serious about addressing crime, I think we have to adjust their rates in
We're
this
all for that.
budget. And what are we doing along those lines? Because I didn't see it, and I may have missed it. I don't know. Is there a proposed rate increase for the providers?
We don't currently have for the providers an increase. What we are doing is we have an opportunity to work with the Medicaid leadership in terms of South Carolina. They have actually been able to pay their providers that deal with Medicaid at a Medicare rate. And so, and they
At least get back to the benchmark, right?
yes, getting back to the
Can
benchmark.
we try that?
Well, what we're asking in terms of the conversation with them is, what is the MOF? They're very similar in terms of state and size, and so we're having meetings with them to determine how did they do that.
That
and then-
North Carolina? I didn't mean to cut you off.
South Carolina.
South Carolina. Okay.
Yes.
South Carolina.
South Carolina. And so
Okay.
we're having that conversation with them because your point, we've got to be able to have providers engaged because that impacts not just mental health, but frankly, primary care as well, because primary care physicians aren't going to be willing to take a large
Exactly.
load because they don't then have the ability to make that referral to a specialist.
Yeah, I get it. And so I'm concerned about how we get there and the tiered waivers. What's the number on the waiting list for the tiered waivers? Does somebody have that information?
Do you have the waiver sheet?
The DD waivers or the OAS waivers? Sorry.
TD.
We'll get that number for you.
Good morning, Julie Foster Hagan, Assistant Secretary, Office for Citizens with Developmental Disabilities. When we switched to the tiered waiver about 6 years ago, we now offer everybody who has an urgent or emergent need for waivers a waiver offer. And so there are people who are on a registry, but their needs are met right now through, if it's a child, often their needs can be met through EPSDT services or whatnot. And so we don't have a waiting list per se anymore because those people who do have the urgent and emergent needs are able to get the waiver offer. And the tiered waiver just means people used to just wait for a new opportunities waiver,
Right.
which is our most expensive waiver without a cap. And now we look at, is there a lower cost waiver that can meet their needs before they move into that new
And
opportunities
the opportunity waiver, where are we with that?
waiver. Pardon me?
You said the opportunity waiver,
The
right?
new opportunities waiver, right.
So there's no
There's
way.
not a waiting list. What happens is we have a process, we call it a bumping process. So if someone's in those lower tiered waivers and that waiver's not meeting their needs because they need more,
So they're bumped up?
they work with their support coordinator to do a justification, yes, and they can bump into those higher waivers.
Okay, well, thank you for that. I'll just end my comments by saying, and I heard some of my colleagues asking about the percentage of Medicaid recipients in Louisiana, and that number was 45 or something.
That's right.
To that. And I just want to add that we have. Okay, we have to do better about meeting the needs because you're right, the mortality rate in this state is off the chain, and we have to address these issues that our women and children and people in the state face. But what I want to make sure my colleagues understand is that Medicaid is 40-some% in Louisiana because we are a poor state, and our wages are so low that almost everybody should qualify because we won't increase the wages of the people in this state and working class people in this state. And so that's part of the issue. But thank you for your work. I appreciate it.
Thank you.
Thank you.
Okay, members, we had a little glitch there, so I got the order from which, so, Representative Owens, you're next, but let me tell you the order in which I had you before that happened. I got Owens, Butler, Fisher, Freeman, Mack. So if you would push your buttons in that order, if you turn your buttons off now, everybody turn them off. Okay. Let me turn Marcel off too. Okay. Representative Owens, push your button, please. Then Butler, then Fisher, then Freeman, then Mack. Okay, now we're back in order. All right. Representative Owens.
Thank you, Mr. Speaker. Thank you, Dr. Abraham, for being here. Appreciate you staff here with ready for a full battery of questions and issues. I don't really have many questions. I just want to leave you with a request, and it is related to budget. I would ask that as we, as legislators, ask questions that they be answered directly and frankly and non-cryptically.
Got it.
I got a lot of cryptic answers over the last 4 years.
You won't get them from us.
Thank you. I was very disappointed when I asked questions about things like emergency use authorization, when I asked things about vaccines for kids that were non-authorized vaccines, and I got cryptic answers, and it drove me nuts. These are public dollars. We are here for the public good, and I trust you. I trust you implicitly, and I'm glad you're in this seat. And we will be I know I will be calling on you, and many of my colleagues will, because we need to get this right. We owe it to the public. And I have a lot of things I'd like to discuss, and we will do them in other venues. I want to publicly thank Bethany Blackson.
She's wonderful.
She has been our LNO, and she answers questions instantly, but she's answering questions other people give her. But I appreciate her promptness and her attentiveness to me as a legislator. But a lot of things need to be discussed going forward. Thank you for your time. God bless you.
Thank you.
Representative Butler.
Morning, Mr. Secretary. How are you? It's
I'm
good
well.
to see all of you. Thank you for being here. Always, my issues, are with direct care workers, and the turnover rate is nationwide. Like, we have a critical shortage.
We do.
Tell me what you believe. And before COVID, it didn't seem to be in the level it is now. Am I wrong about that?
No, you're exactly right. We see it on the private side too, just finding that quality hire that knows their job, that cares about their job, cares about the patient.
Right.
With COVID, it was such a large public health emergency that the employees were just snatched up as soon as they became available. Even on a very small level, at the clinic level, where I practice sometimes, is that it's just hard to find help. And I'm not going to qualify that with good help. It's very difficult to find very, very good help. But just finding help is very difficult.
What do you think the reasons are at the level we're at that we are going to have to do to change that? Because I look at our budget and I see what we have and what we don't have.
Right.
And I know that pay is always there. Training is a big issue, I feel like, and I do have some legislation coming from
Good.
that, so let you guys know that. But pay, so I know that in 21 we had given a $2.50 allocation to direct care workers, correct? Am I correct with that?
Yes, ma'am, 250.
Okay, so what part of that went to the direct care worker? What percentage of that?
So I'll let our OCD team give you the details.
Julie Foster Hagan again. So what we did when we calculated that, there was a lot of discussion with JLCB and some other folks. And what we did is there was a request that the majority go to the worker. So we pulled together some different meetings. What we looked at is a 70% increase to the to the minimum wage. And that's where we landed on the $9 an hour going to the direct care worker. And so in rule, it requires that direct care workers in our home and community-based waivers receive a $9 an hour, excuse me, a $9 an hour rate. We did an audit on that. We did find that there were some who were not in compliance. They received letters from program integrity and fines and sanctions if they did not, and they were required to go back and make sure they were meeting that $9 floor.
Did the full 250 go to the direct care worker? Some went to the provider.
Yes.
Correct. Do you know
Yes.
what that amount is?
We don't have the exact percentage of that, no.
Okay.
Because it varied depending on what the rates were that they were paying before the increase and after the increase.
Do you know why they didn't comply? Have y'all found out why some of these departments haven't, some of these care provider places did not comply with the raise?
With the $9?
Yes, ma'am.
I do not know. We just, I know that we notified them and gave them an opportunity to correct what they had not done. And then I'm not sure. I'd have to check with my team to make sure we went back
Okay.
and verified that they were all meeting that floor.
I'm going to tell you what I received, and then we'll talk about it at a later date. But that 30%, which is only 75 cents, went to the direct care worker. The rest went to the provider. So I'd like to maybe have a discussion on that, and because
And there is a report that we submitted to the legislature, so I can make sure, Red
Yeah.
Butler, you have that report.
that's not going to fly, not with me. So we're going to have to talk about that. Thank you. I appreciate you.
Representative Fisher.
Mr. Chairman, actually, I think this question is for Ms. Foster with OCDD, Home Community Waiver. And I think Rep. already may have asked this question, and I wanted to see some clarity on it for the one-time ARPA funds that were passed through to the providers for the Home and Community Waiver workers. So we were told, I think, last spring that they would be permanent. And so I think of the gentleman next to Dr. Abraham, and happy to have you here, Dr. Abraham. So we very happy that you're with us. So
Thank you.
Yeah. But when will you find out, or what date will providers be given a notice if that rate would change and not be permanent for the ARPA funds, for the one-time ARPA funds that were passed on through the caregivers?
So we had some rate increases using ARPA funds for the OAAS, the direct support workers in the Office of Aging and Adult Services, and we had some Rescue Plan Act dollars we were using for support coordination agencies. It was a 30% rate increase in both the Office of Aging and the Office for Citizens with Developmental Disabilities in the fiscal year 25 budget. It's all in the base budget, so it's not funded through ARPA any longer, but funded through the base budget.
So now, so now those funds are permanent for those providers?
Permanent unless we have budget reductions and exercises that
That's the
we.
budget it is.
Yeah.
Okay. Also, let me say this. The providers are very thankful for the increased rate of $9 per hour for the direct care workers. But I think just like it's challenging to have staff in AMS and Villa, it's even probably just as challenging, I guess, retaining staff for private providers at $9 an hour. So I think if we can somehow increase that rate so we can really make sure those individuals are being taken care of in the community, that'd be very helpful.
You're exactly right, Rep. Fisher. We truly wish we could raise it today because, as you know, out on the private side, they're sometimes offering starting $15 to $18 an hour, and we're down to $9. So, you ask why there's a shortage of help. That is the answer. It's just that disparity in the wages. It's just such a big delta that right now with LDH, with our budget, we are very constrained as to what we can offer those good people.
Yes, sir. The other, I guess, statement I have or suggestion or insight for the training for the HCBS direct care workers. I think it'd be helpful if the state can provide like statewide training to all those private providers to make sure that what's expected from those workers is coming directly from you all, and that way they can be held more accountable for what they should be doing. So if it comes directly from you all, just as across the board statewide training for all direct care workers or providers, then I think it'd be more effective. Just statewide.
Yes, sir. And so we are, right, we've just started a program where we do offer that for direct support workers. The training is from our staff on a variety of topics like person-centered planning, recognizing signs and symptoms of illness, how to prepare for an emergency. So different things that are relevant for our developmental disability population. We make that available to providers and direct support workers across the state. We're also partnering with some community colleges across the state to build in. They have something called a mental health technician, but we're working with them to build curriculum that would add a component for working with folks with developmental disabilities to that, kind of like as a specialty, so that we can have folks more trained and more aware of services that we provide in our developmental disabilities. So we're working on it. We still have a ways to go, and I agree training is a critical component. We'll continue to work on that.
Okay. All right. Thank you.
Representative Freeman.
Thank you, Mr. Chairman. And thank you, Secretary Abraham, for, first of all, for your focus and discussion in your remarks about crime and mental health. I have about 4 questions. They're not all related to that, but I will say, and I'll follow up to Rep. Marcel's question because she asked parts of my question there. But from what I understand, the reimbursements for mental health, and she said this, they haven't gone up since 2012.
That's correct.
I represent 2 hospitals in my district and many mental health professionals. So I'm constantly getting calls from those mental health professionals about that poor reimbursement rate.
Right.
So I'm excited to hear what results may come out of the South Carolina discussions but I also know, and I don't know if you all are aware, and I'm sure those at LDH who've been there previous to your beginning of your term, that there were 3 different LDH studies from 2023. One was for mental health addiction. One was for mental health, and one was for addiction, and they were all LDH studies on reimbursement rates. Mm-hmm. And from those studies, evidently, and I've been talking to some of the addiction treatment centers about this, if we can put, the number I was given was $27 million of state general funds brings us $55 million in federal dollars. So I would love some further, maybe a conversation post this meeting at some point about, I understand that we are in a budgetary strain and we're dealing with this 0.45 sales tax rolling off, but to me, if we could find the $27 million and put that there, that's a help with the crime.
But exactly to your point, Representative, we, Michael and his team, Pete, have had and will continue to have discussions with CMS about this same issue. We actually went up to D.C. a few weeks ago, not on this particular issue that you're addressing, but others. And we were greeted warmly and very fairly, and got some good results from what we went for. So these discussions are ongoing. Michael, as he has alluded to, has been talking extensively, not only with South Carolina, but other states too, to try. And we know at LDH, if we can get that Medicaid rate to a Medicare rate, we can get those providers that right now are unwilling to come to the table. But not only in mental health, but in other specialties that we are lacking in as far as Medicaid, and that would be gastroenterology, cardiology, you name it.
Sure. No, I realize it's
We just
affects.
got to get up. Mike, you want to address that a little bit on this?
Yeah, I do realize that it affects all the different
It does.
reimbursements, but I just know that you said you had a focus on mental health, and I know the governor
Absolutely.
has a focus on this
He
as
does.
well, and I fully agree with the governor and you that anything I can do, and
Thank
like
you.
I said, other meetings may need to happen outside of here, but if I can be included in any updates,
You're welcome
and if I
in
can
any
be
meeting we
helpful
have.
in any way with
Yes.
conversations. I know
We-
that matters a lot
we will
to
keep
the
you
mental
very
health
much informed.
professionals
Yes.
that live in my area who are.
Yeah, absolutely. Thank you.
Did you want to add anything?
to that?
The only thing I was going to add is that, I mean, my experience has been as a hospital executive. And so I spent years trying to address mental health in terms of equity of pay and services. And certainly when I hear about the direct care worker being paid $9 an hour, I mean, I have to say it was one of the things I was most taken back by. And so we are very much focused on how do we get it to at least a level playing field in terms of the reimbursement. And I do think we have some options in terms of CMS. We have a call set up with them to follow up on several items, not just the F&P that they gave us another year on, but also some of the other options that we have to take a look at this issue with the funding piece. So your point is well taken. It's going to take us a little time to try to figure this out, but those studies, I'm sure they're there, and we will certainly not reinvent the wheel to be able to do that. Thank you.
Thank you. And my second question, you also mentioned in your opening remarks, Dr. Abraham, about maternal health outcomes.
Yes.
And we know that we are the worst. If
We are.
49th or 50th, it doesn't
Right.
matter to me. I mean, so what specifically is LDH suggesting we, as a legislative body, put into the budget in order to help have better outcomes? I mean, I did see, I believe, Representative Almody referenced the pie chart of who rolled off, and that was 4.4% of that chart was pregnant women. And I mean, I understand that we have a hard time getting in touch with some of these people because they are more transient and they do move around. What specifically does LDH look to address on the maternal health?
Before we ask you specifically for future funding, we are asking ourselves where we are lacking in maternal health. Tomorrow, Dr. Krog and Pete to my right here and the rest of the team are meeting with a large contingent of our public health units that see these ladies on the front line. From preconception, during the pregnancy, and certainly after the baby is born. What we're finding, looking internally at where we can do better, is that we're missing the boat at our public health units, not that they're not doing their job, that maybe we're not providing them with the tools to do their job from our aspect of my position. So this is something we're looking very hard at, testing of urine for certain issues that right now we may not be testing for. Measuring simple things like blood pressure, the girth rate of the pregnant lady, and making sure we don't have a intrauterine growth deficiency in that child. So there are a lot of things that we have discovered that could be done that we're not doing. We will start doing those, and that meeting that we're having tomorrow will start that process where hopefully we can give our public health units more direction, more concise direction as to what they need to do and what we can do to help them get there. So it starts at the very beginning of that pregnancy, and it continues throughout, but we've got to have that continuum of care, to your point. Getting that pregnant lady to come in, finding them sometimes is a challenge.
Agreed.
And we've got to find a way to make that happen.
Well, and so I appreciate everything you're doing to look into that. Again, would like to be kept updated. I mean, I can't speak for the Women's Caucus, but I do think this is an issue that's a bipartisan issue for us, and we are a bipartisan caucus. So
Yes.
I can't speak for our chairwoman, Senator Mizell, but I would say Senator Mizell and I have had private conversations about how important this is to our
and
state.
I'll make this comment publicly to every member of this committee. You are welcome at any meeting that we have internally. Again, we want to be very open, and you guys need to know what we're doing. And if you don't, you need to ask the questions of what we're doing and why we're doing it.
Well, and of course, I know you'll agree that healthy moms lead to healthy babies, and,
Absolutely.
and that is part of the we need to have them in the care.
Part of the infant mortality, a large part of it, of course, is the addiction issue.
I do know that.
The other part of it is preterm labor. And preterm labor, I would say, and Pete, you can jump in here, but I would say preterm labor is probably 90% preventable. If I can catch that asymptomatic bacteriuria, that bacterial infection in that urine that's not we're picking up, or if I can pick up early where that child is not growing in that womb and the reason why, then we can prevent that preterm birth, and then we can prevent that infant mortality.
My next question is to deal with, I know you practiced many years as a primary care physician, and I don't know if you still see patients today, but you do. I thought you did.
When I can.
When you can, yeah. And I appreciate all the work you've done understanding, the population of the Medicaid population because of your work on the front lines as a primary care physician. What programs is LDH funding or suggesting that we fund for programs to deal with that whole, you hear more and more, food is part of your healthcare. Food is your medicine, right? And one of the things, obviously, that I've been very concerned with, and it came up during the crime session, is that we did not fund the summer EBT, which I realize is not for you to answer. But what I will say is that we do know that access to programs for the children and the parent, whether it's a clinic in the school or, sometimes the nurses visit the schools, what programs is LDH actively working to grow in that area? Because I know some of this population, the only time they see a nurse or doctor is when someone comes into the school or when someone comes to give them a talk about nutrition. Or some of the public schools in my area actually have gardens now, teaching children how they can grow things in their backyards to eat.
Well, I'll just say a preface, and then I'll turn it over to people here on my right and left and behind me. But a child, they're not going to learn if they're hungry. They've got to have that full belly. And if that's a breakfast, a lunch, whatever, we've got to find a way to feed that kid. Because if we don't, they don't learn. And so, Pete, you have anything to add?
I would just add that probably our most robust work is in our Office of Public Health, our Bureau of Chronic Disease, also known as Well Ahead, and our Bureau of Nutrition Services, Bonds, which oversees the WIC program. And they've been doing a lot of creative thinking about how do you lower the barrier of access and make sure that if someone's eligible for WIC, they're able to access it. We've got some really long intake appointments. We've got challenging hours for working moms to be able to show up at some of these appointments. And often the clinics are not where moms are when they really need to be enrolled, which in a lot of cases is at the time of delivery and leaving the hospital. So I think it gets back to coordinating care for moms. Yesterday I saw a mom in my clinic with a blood pressure of 173 over 120, that she was 5 months postpartum, and no one had been following it until she showed up for an addiction medicine appointment. And there's too much disconnect for how much we're spending. And I think that's something that we can coordinate, and it takes all aspects. It's blood pressure, these preventable conditions, addiction, and treatment, nutrition.
Yeah. So, I appreciate any programs that you all continue and, letting us be as representatives a way to tell our own districts how those programs are available. Many people have town halls and neighborhood meetings that they attend, and getting that word out is important because it is. We're not going to change outcomes if we don't address the beginning of people's lives, and to that point. So I appreciate you sharing your clinic information. The last question just came to me after we were answering questions about the bad data from the federal government. If Equifax is doing a better job, which I would assume they would be, based on my knowledge of data transfers and the work I've done in the business community, do you have the cost of the Equifax package versus the federal package? Are we saving money by using Equifax?
Actually, Equifax is a little bit more expensive.
Well, if it's good data, that's okay
but
too.
we are able to pay for it in the current budget because it's going to give us better data to make decisions. So we're not asking for more money to be able to do that project within the budget.
I do appreciate you all connecting and figuring out the data was bad. I don't care where the bad data comes from. You've got to have good data, because data in, data out. You all are researchers and doctors, so that's true on the scientific side, but with Equifax is constantly updating their databases. Yes. So. Thank you so much, and I look forward to further conversations on some of these topics. Thank you, Mr. Chairman.
Representative Mack.
Thank you, Mr. Chair. I want to say thank you for presenting today and for answering our questions.
Thank you.
I'm excited about our new leadership, Dr. Abraham and LDH. And I want to say I'm excited to see the positive changes that come with that new leadership.
Thank you.
I truly believe the people of our state will be taken well care of at the lowest possible cost under your direction. It's important to me, I want to let you know it's important to me to do the best job we can to take care of the people with developmental disabilities. So today my questions deal with Medicaid and the Office for Citizens with Developmental Disabilities. And so my first question is, I've been hearing about the Medicaid buy-in program for people with disabilities. This program allows people to work and earn a living wage without losing their Medicaid. It's a good program.
Agree.
Where's the department on restoring this program to allow people with disabilities to earn a wage without losing their Medicaid?
Thank you, sir. I think this is actually a perfect example of what Doc was saying about asking for new ideas from staff, because I think within 2 weeks this came out of our OCDD office. I assume you're referring to the Medicaid purchase plan that would allow folks to potentially pay a nominal premium to keep working so they retain their Medicaid eligibility if they have a disability. We think in concept this is exactly aligned with moving from dependence to independence and supporting people in the workforce. We're really just trying to work through the projections and the funding aspect for it. I think how many people would sign up for it is difficult to predict because a lot of our prior data is from over a decade ago, but that's something we're working through, and I think we're really interested in the program.
Appreciate that.
And to your point, you've heard me say it, I think, before. I've never found anyone that wanted to be poor. I've never found anybody that wanted to be uninsured. We have also had this same conversation with CMS on the federal level. I've had this conversation with the governor. Nobody wants an uninsured patient because, one, it's terrible for the patient because their only option then is the emergency room. They don't get that continuity of care, and it gets exponentially more expensive for us as a taxpaying citizen. So that concept that you have addressed is something we are embracing. The governor wants to embrace. We don't want somebody to be uninsured. And if we can find that sweet spot where they can do some work, keep their insurance, that's a win-win. Right now, as you know, the system is that people are literally afraid to take a higher wage job or even to take a job because if they make that $1 or $2 more, they're kicked off the rolls.
Right.
That's the worst thing that can happen.
Right.
So your point is, I think, outstanding, well taken. We certainly are looking to make something like that work.
Once again, I'm excited you're in that position. I really, really am. So I want to say this. I got one more question. Home and community-based providers are struggling with paying for a nurse. Okay. A nurse is required to do certain tasks not being able to be delegated to other health care people that provide that service, the nurses' aides. There used to be a code years ago, and it's my understanding that advocates have been trying to get a new code to allow providers to bill for this service so that the providers could bill for this service that the nurses actually provide. Is the department working on setting a new code that would allow this?
I know there's been I know somebody behind me is coming up, but we're having that discussion. And as you know, on the federal level with the Medicare patient, not necessarily the Medicaid, but there are codes that do address that. So
Okay.
we need to find that code. Julie, go ahead.
Hi, Julie Foster Hagan again. There was a code. We did, I believe it was in the 2022 regular legislative session. There was a House resolution that was passed that asked us to study that. We did do that and presented that report to the legislature. There is a fiscal note tied to it, and so We are, open to exploring that. We've had some discussions with some of the home and community-based providers around that, but it would require an ask from the legislature to add that to our budget to be able to do that.
Okay. So maybe later we could work together to determine how much or see what
I
that.
believe we have a fiscal note. Yes. We do have fiscal information for that we can provide to you.
Okay, thanks. That's all I got, Mr. Chair. Thank you so much for letting me.
Representative Lyons.
Thank you, Mr. Chairman. Congratulations and welcome. I have to ask a question in regards to individuals with mental illness. In the past 3 to 4 years, the percentage of enrollees who are eligible have not actually had, the numbers have decreased in case management care, and we've been delegated to more of the text phone interview process with those individuals with far serious mental illness indicators are falling way below the line. So I was trying to go through the slides where we were to identify the actual budgetary line where that particular category was at. But when we start talking about mental illness and we start talking about how do we really get into that whole paradigm of working with that piece, we have to get away from the one-size-fits-all method. We have individuals call and have interviews via text, via, those conversations have to be in-person care. So right now, I think we're almost at 12% of the number of individuals with mental illness that's enrolled in that process, down from 50 at least a couple of years ago. What's the plan, or is there a plan in place to address that?
That the face-to-face is a very necessary part of mental health. The texts are good, the phone on the face is good, but nothing beats that person-to-person contact. You have to have that relationship. Now, on the LDH side, we have some mobile response teams where we can get to that particular patient if they call or if they're having a crisis. And our standard is if you're in an urban setting, we'll be there in an hour, and if we're in a rural setting, we'll be there in 2 hours. Now, if we are actually able to connect with that patient, help them, then there's a community-based net that picks them up for the next 15 days. And at least that gives us time to find that hopefully permanent solution or that permanent place where this patient can be helped. So, Michael, I know you got some input on some of that, those connections that you've talked to. Anything you want to say?
No, I to your point, I mean, when we're looking at programming, it's looking at how to, again, have reliability. And with what you're talking about with text and those kind of things, they're not providing that. And so anytime we're looking at outcomes, and to Dr. Ralph's point earlier, and as it was mentioned, we're not getting them, we're looking at a totally different type of process to gain and measure outcomes, so that it is much more about not activity, but actually the result of the intervention.
Well, now we're at that point. Who measures that? Where is accountability with the health plans that are there right now to make sure that they're providing that particular part of the program that's there? Well, I'm looking at the numbers, and the numbers are showing, and Dr. Abraham, you talked about the money we're spending and what we want to spend it on, but the overall accountability to those health plans, who's watching that? Who's the keeper? Where's the oversight in that?
Go ahead, Michael. You'll answer that. I want to.
Yeah, I definitely want to answer that because I think up to this point, the staff, again, have been doing a good job of tracking what's there. I think from an LDH standpoint, we have to have far more assertion about what the actual measurement is going to be. And it can't be activity-driven. And what I mean by activity is that you're showing up at a committee meeting or you're turning in reports and those kind of things. What we're looking at is actual outcomes in terms of the patient. And we are the ones that are then establishing what that criteria should be, us being LDH, and we're the ones that are then tracking. But also, when it comes to the MCOs or providers or anyone else, we're going to have very much an approach of trust but validate. It's one thing to get it from the MCOs, but it's another thing to be able to validate that information. But I think you'll see a very different approach in terms of quantifying and tracking in terms of outcomes as far as it relates to quality.
So where would I be able to look at those metrics on a semi-annual or quarterly basis to know that, number one, LDH is prompting the health plans to start measuring those pieces and start changing the activity about that and the success of it? Because I'm gonna have to wait till we come to budget hearings again next year.
Oh.
Well, sir, I would ask you, and I appreciate your candidness, but I want to make sure that we can put our fingers on that and watch that as we go forward.
We'll be putting our fingers on it monthly. And so if you want a quarterly or whatever kind of update you would like, year to date, normally I look at things on a month and then year to date basis to really see what the trend is.
Can you share that with me?
No, absolutely.
I appreciate it.
Yeah, we'll be happy to share, and I'll add my 2 cents to it. When you're talking about MCOs, the first word of that is managed care.
That's correct.
On our deep dives, since we've been on board, they're not managing care very well in some cases. We've had some very direct conversations. Michael, we call him, he's our money guy. He can look at a budget and he can see exactly where something is askew. So when they try to kind of pull the wool over our eyes, no. Michael, Pete, Drew behind me, this entire staff, they call them out. And now they know that they are on point and we are watching the hen house. And if that doesn't happen, you come directly to me because that's on me for not doing my job.
Well, thank you, sir. I appreciate that. That's all my questions. Thank you, Mr. Chairman.
Representative Chairman Romero.
Thank you, Mr. Chairman. And good morning, Dr. Abraham.
Good morning.
And Michael, thank you all for coming and the rest of the staff. And we've met offsite on this, but I just wanted to ask you the amount that providers are getting for providing care. I know we met with a provider from the Lake Charles area that was taking care of 16,000 Medicaid children, and they're getting to the point where they may not be able to do that anymore. Right. And it's going to be a crisis. And I'm sure if it's happening in Lake Charles, it's happening statewide. What is your plan? And maybe give a timeline on when those things might be able to change and go back to providing the amount of dollars needed to keep those doctors, providing good care.
Yeah, the timeline has got to be as soon as possible, and I'll let Michael answer too because he's been in those direct talks with the South Carolina people. We've got to get that rate up to the Medicare rate. We got to get it up more than it is now because, again, that meeting that you're referring to, you've got these wonderful providers and these wonderful clinics that are fixing to bail on the Medicaid program because they can't keep the lights on under the amount of money that that we as LDH are paying them now. Michael?
And part of this is they've had the FMP, which was to be a supplemental in terms of physicians. Reviewing that particular case, we are not, and from an LDH standpoint, we are not the ones who are deciding that distribution. So I have provided additional data in terms of where that supplemental support is, how close that gets them to the Medicare rate. But the difficulty is that that is not for all providers. And so what we're proposing is finding a means of finance that would then reach all of the providers to be able to have it in the base rate. And I think that, as we've said earlier, will be a monumental change. Our goal, if we could do it by beginning of fiscal year, would be wonderful, but I don't think that's going to be the case because of looking at the means of finance. But we definitely want to have a plan in place when we're looking at beginning the budget for next fiscal year in terms of that November, December timeframe that we'd want to be able to bring you.
Thank you, Mr. Harrington. Thank you, Mr. Chairman.
Okay. I ask a few questions. We got a couple people that want another bite at the apple, but I'm going to take my bite at the apple. So Medicaid expansion occurred, I guess you can say probably our freshman year, Z, of our first term. We're 90% on page, here, I'll go to slide 62. So every year we see an adjustment for the federal match with CMS that provides the state for our Medicaid, and based on the formula on page 62. Is there a rule of thumb on how much state funding and federal funding is shifted from the 1% change in FMAP?
Can you say that again?
Is there a rule of thumb on how much state funding and federal funding is shifted from a 1% change in the FMAP? So if that FMAP changes 1%, how much funding does it require in state and federal funds?
I don't know that I could give you that exact number right now, but I can calculate it with a team and be able to do that. I'll ask my team. Yeah, we'd have to make sure we calculate that and get that back to you, but we will do that.
All right. Next thing, we spent the last year in here talking about the roll-offs, the unwind, and the significant number of individuals that was estimated, and then the numbers were even higher. And I see that on page 60. The state general fund is $147 million. So the majority of the individuals that rolled off and didn't re-enroll, was it based upon their not being qualified because of the changes from the COVID?
Yes, and the fact that, there was really no criteria for them to roll on, except that it was declared an emergency, but the roll-off, now they have to be eligible.
Okay, well, that was my next question. How many of those individuals should have qualified to begin with? And were those responsible for determining those qualifications? Did they do their jobs accurately?
No.
Okay. And I appreciate the directness because I've been asking that question for a few years. Because there was several hundreds of millions of state general fund dollars. In addition, that was resources that others needed to utilize as well. Now that that roll-off has occurred, and the savings for 51,000 coming off next year is $147 million of state general fund. Are you projecting this to level out now? Is this kind of where it's going to be with Medicaid, the expansion part?
Go ahead, John.
Yeah, I would say that based off of what we're seeing now, because I don't know that we can answer that in terms of leveling off, because we've got that 300,000 that are sitting there that anywhere between 14 and 19% of them could qualify. When you look at the churn, for instance, that happened in February alone, that was 19% that was able to then come back on. Mm-hmm. So I think that as we go through this next year, we will have a better sense about that, Representative McFarland, because right now those variables are pretty high in terms of that 300, because many of them will qualify. The other thing we're doing to be able to get a better handle on that projection is that we're also instituting the wage checks that previously had been suspended during the PHE. So we think between getting better data, certainly being able to have the wage checks, that actually will start in April. And then the first roll-off in terms of related that would be in October of 24. But until we can get through a lot of this 300,000 that are sitting there, it's going to be hard to do that projection.
Okay. So last year at this time, I asked a question in this same committee about provider services contract. And that contract, there was the NASPO, they were LDH, as I appreciated, invited different providers that qualified it from NASPO to make a presentation. As I appreciated in testimony and in conversations afterwards, and then and a follow-up at JLCB 6 months later, where I did not get an honest answer, and I played back what I asked from a year ago, and it was misleading. Where are we at with that contract, and where are we going? Is it going to require, can we not just go back in and resubmit it? I mean, it doesn't have to go through the procurement process again, as I appreciate it. And it's not the only one. I mean, we have a claims processing, and I know it's under litigation, but.
This is our legal stuff. Yeah.
Okay.
Good morning. Kim Sullivan, the Medicaid Director. Are you talking about the NASPO procurement for Optum, the provider management module?
I am.
Okay. That is currently sitting in a protest with the Office of State Procurement. So we are prohibited from moving forward with that at the moment.
Okay. My next question to that is, and basically pretty much what I asked last year. So we have companies come in that are on the NASPO list,
Correct?
qualified. You have one come in late. We go back through the process and give that one an opportunity. They come in at almost double the amount of some of the others that sent in the same request. And I'm sitting here knowing I have a $558 million shortfall next year, and I'm trying to figure out why LDH is accepting a bid of $100 and something million when we got one that made a bid that was on the NASPO list, which means it qualified for $53 million.
It's a very legitimate question that we are asking also why that happened.
Okay.
And Representative Farland, if I could, I was just speaking with our general counsel, and what we've looked at, to your point, is actually starting over. Basically, clean the slate, start back over, make sure that there is clarity in terms of comparison. Because what we found is that if you start adding different modules in terms of IT, what's included, then you're not really comparing apples to apples in terms of the actual bid itself. So we're going to be very clear about what we're putting out as an RFP, or we're going through NASPO to be able to do, and we're going to start over with that, to your point. And we are going to be very judicious when it comes to selecting contractors as far as money.
And Mr. Chairman, how crazy, and I'll use that word, the RFP process is.
It is.
That if there's one protest, the train stops dead in its tracks, and you're just hamstrung as to where you can go from there. It's just, in my opinion, insanity.
And the NASPO list, as I appreciate it, was supposed to make this much easier, much more simplified, because they had already qualified for NASPO. And regardless, I don't care which company it is, it made the process easier. But the process that concerns me is that we look at the numbers. And when I look at those kind of numbers, and then my good friend Tony Bacala, who's now chairman of retirement and not in here with us today, I know he'd like me to ask the question, but it's already in litigation about the claims processing. He asked that linked for the last year about, so are we establishing a better method? And I understand litigation and the challenges and the protests, but can we come up with a better method when we're trying to secure these programs where we don't end up in this position? And is any of this self-inflicted? And I really know I'm only supposed to be discussing the budget, but it does affect our budget if we don't do it correctly.
Chairman, the way I can answer that is in the transition meetings that we had with the governor. He, too, was pulling his hair out at the mind-boggling process of how quickly it could be derailed. So, yes, it's an ongoing conversation. As if you ask me today, has anything changed? Of course, the answer is no. But if you ask me maybe 3 months from now, has the process changed? I hope to give you a different answer.
Okay.
And Representative McFarland, if I could, to your question about self-inflicted, yes, some of this is self-inflicted, and we're working with our council to be able to not do that in the future.
I appreciate that. And look, and I know that it's challenging when you change an administration. I was here for the first administration change 8 years ago. That one lasted for 8 years. Now I'm going to make it through one term of this one, and I'm going to let y'all have it after that. I know there's some applause and some people celebrating. One final question I have is the payments for the waiver programs comes out of the Medicaid's budget. How much oversight does OCDD have in waiver services and the Medicaid payment rates? Got it. I knew I'd get her back to the table. I mean, they're playing musical chairs, them two.
So OCDD helps to establish those rates. I think we mentioned earlier, Michael told you guys earlier, we're looking at using some of the Section 9817 American Rescue Plan Act dollars that we still have to do an actual rate study where we would pull folks in. But typically when the rates have been set, that does come from our office. We make recommendations associated with those rates, and we have the rules, I guess, around that rate setting.
Okay. All right. Look, only got a couple more questions, and we're going to see how this goes. Representative Fisher.
Thank you, Mr. Chairman. Mine very brief. I want to acknowledge Dr. Sizer with the Northeast Delta Human Service Authority for the work they do back in our area because he takes some very proactive initiative, get community buy-in, community involvement, and really go into those rural areas like Farmerville, Lake Providence, Tallulah, Bastrop. So I wanted to acknowledge them for the work they're doing and hopefully just keep doing it that way. Thank you.
That's
Thank
where I
you.
live too. Yeah.
Representative Marcel.
Yes. Ms. Julie, can I ask you a question, please? I'll be very brief. I got a question about the tiered program.
Okay.
Tell me, how does that operate? Because I heard somebody mention it earlier. How do you all operate the tiered program?
Sure. And so we, like I said, we started about 10 years ago doing what we called a systems transformation.
So it's nothing brand new?
No, it
Nothing
started
just
6
came up-
years ago.
Okay, I thought
Right.
the way
and
I
one
heard
of
it
the things
presented.
that the advocates told us is that they wanted us to end the waiting list. So we worked collaboratively with a group of lots of different stakeholders, providers, families, the Developmental Disabilities Council. A lot of the folks you see behind me in the yellow shirts who are here all the time were part of the meetings that we had. And what we did is we used to have people who would get on a waiting list, and then they might have to wait 12, 14 years before they ever got a waiver offer. So what we did is instead of doing it on what we call a first come, first served basis, we changed to do that based on priority. So what happens is somebody gets it's a screening, and we call it the screening of urgency of need. And based on that screening, they get a score of a 0, 1, 2, 3, or 4. 3 or 4 means that, it doesn't mean that your needs are severe. What it means is that if I don't get some supports, and those supports have to be supports that are available through the waiver. If I don't get something now, I'm at risk of having to leave my home and go into an institution. That might be jail, might be a hospital, might be a nursing home, might be an ICF. It could be anything other than your home and community-based setting. And so for those people who score a 3 or a 4, they get a home and community-based waiver offer. Those people who have a score of a 0, 1, or 2, those are the folks that are still on our registry. If their needs change at any time, they can call us and get a new screening. And if that new screening then shows their needs are now at a 3 or 4, they need services to help them stay in the community, then we can make them a waiver offer. Once that offer's made, we then go through that process I told you, which is the most appropriate. Can they be supported in the Children's Choice or Supports Waiver, Residential Options Waiver? Those are considered before moving to the now.
Okay. I thank you, and I want to thank the department for their continued work. I just want to make sure that people knew that these were programs that had been in the makings for quite a long time and included a lot of the people that are sitting in the audience that I'm looking at. And so this is nothing brand new. This is something, the work that y'all have been doing. I appreciate the work that you've done. And then I think under Secretary Phillips, there was some additional training that was also developed. Is that accurate, Ms. Julie?
We have done ongoing training. We do occasionally hear concerns about some of our processes. We're always very open to hearing what those concerns, hearing what's working. We call it what's working and not what's not working. You'll hear us say that a lot. And we know that there's always improvements we can make, and we definitely want to hear from folks when it's not working to see, do we need to do training? Do we need to look at making our processes more efficient?
And y'all been doing that for a number of years.
We do that ongoingly all the time.
I thought so. Okay, and that's it. Thank you so much. I just wanted to clear that up. I thought I had remembered, I've been here 9 years. I'm getting kind of old, so I thought I had remembered y'all did some training, and a lot of the folks in this room had a lot of meetings and a lot of input in what you guys did with the tiered program. So I want to make sure some of my newer colleagues that may have thought that this was something brand new that just popped up this week, that it was not. And that's all I have for you, Ms. Julie. And finally, I do want to you said you had an open door policy. I really appreciate that. I want to have some continued conversations with you regarding allowing more private individuals to help us with this budget. Because we are talking about budget. I'm like McFarland, but we've got to figure out ways that we can alleviate a lot of the, I don't want to say waste, but a lot of the funds that we're using for different ways, be more innovative. And if there are dollars that we could better utilize by outsourcing that to private industry, I really want to see us go in that direction more frequently than not. Thank you so much. And I'd like to meet with you.
Anytime, you know that. And to your point, we're a public entity, and we are government agencies per se, but we've got to run like a business. The guy on my left here, Michael, he brings a wealth of private business acumen, having run a huge hospital in Miami. Pete and all the people behind me, they understand that we have to spend our money more efficiently, more effectively, and again, to Michael's point, not to activities, but we've got to get results.
Yes, I appreciate that. And I know we have been moving in that direction, and I just want to make sure and see what your plan is, because I've not had an opportunity to sit down with you as it relates to that. So we want our people to get the right service, but we want to get the best bang for our dollar, and I thank you.
And I do want to give a shout out.
Right, I don't want to privatize everything.
I got you. Well, I understand.
But I want to give
a shout out to Courtney Phillips and Steve Russo, our predecessors.
Please do.
Who, they have been wonderful in the transition. They have been most helpful. And they did some phenomenal work in their tenure. We want to certainly take that to a
certainly,
higher level.
I'm sure that if you reach out to her for any assistance.
Trust me, I have.
You have?
I have.
Oh, well, see, you're a smart man. You're a smart man. Dr. Phillips is a smart woman, and she knew quite a bit.
At every instance, both her and Steve have come to our help.
Thank you so much. Mm-hmm.
Representative Butler, final question.
Thank you, Mr. Chairman. Are you ready to run yet?
You mean out of the room?
We love you. We're just trying to get to the bottom of something.
This has been good.
So, first of all, long-term care in our budget for mental health care under the age of 18. Do we have that separated in there? I know we have, mental health care facilities. Okay. Thank you. The only reason is I've probably gotten 5 calls this week.
No, it's a great question because, where we're seeing such a need. I mean, the need is great all across the demographics for mental health, but the adolescent mental health population, wow.
And it's been a combination.
It's a huge gap that we need to fill.
Right. I think we've talked about that over and over,
Yeah.
that, when our mental health care facilities were closed, I don't know how many times it was such an injustice to this state, because we had adolescent units, we had, women's and men's units, and now we have nothing, and we're having to rebuild. And now we're paying for them to be in jails, and they're homeless, and
Yeah.
whatever that cost is to our
A
state.
lot, and it's terrible for the patients.
Yes, sir, and the
Karen, you wanna-
families. I'm
Good morning.
sorry.
Karen Stubbs, Office of Behavioral Health. I thought I was going to make it through without testifying, and I get the
I'm
last
sorry.
question. No, ma'am, it's not broken out by adolescent versus adult. It would be either in the OBH budget or in the Medicaid budget, but not divided by age
Okay.
category.
I'll have another meeting with you guys at your office about that. Okay, thank you for that. My next question is, every year for the last 3 years, Louisiana DDC has put in $500,000 into the budget, and the legislative, I just want to go on record saying that we have all agreed to that, putting their $500,000 into the budget, and it's been taken out of the budget every time LDH submitted that in the past. So I would like for you guys to look at that and recognize that for me, if you could do that going forward. Thank you very much. One more question. The efficiency and being effective with LDH in the last so many years, I believe they worked really hard, and the staff to do what they need to do, but we also have to remember collectively as a group, your business rates go up. When you have a business and you run a business, to effectively run that, it always goes on to the consumer in my business, which is sad because I provide a service. But, inflation is there, fuel goes up, and all that affects us as well. And so to effectively be able to run that, we have to be able to help you do what you do when it comes to funding. And I agree with that. So hopefully we can come to a meeting of the mind and find a way. Mr. Chairman.
Thank you.
Thank you.
Thank you, Ursula.
Gentlemen, I know it's been a couple, 2.5 hours. I do appreciate your patience and the thoroughness in which you answered the questions. I appreciate the staff behind you. I know
They're phenomenal.
I know there's some new faces. I know there's some existing faces. Some of you are back. I appreciate you staying, at your commitment to the state, that you continue to work even through different administrations. I know as employees, you may not always hear that or get recognized for that. And I know it can be challenging, but as a legislator, I appreciate that because you have a wealth of knowledge. And the only way we can get this right for our citizens and the people we all represent is if we're all working together on this. So I appreciate your efforts and working with the new administration. And I hope we weren't too bad on anybody, but we didn't have Bacala in here either. But we may bring him back now, so don't think you out of this.
We love Tony.
We're going to have him in joint budget or something just to keep you tuned up. But any other words before we, hold on, I got a question. I'm sorry, Representative Lyons.
Thank you, Mr. Chairman. I was not really taking a second apple a bite, but I wanted to get my tea, and I wanted to let you leave. I had a question. Developmental Disabilities Council. I noticed when we're looking at one of the slides in there, we had a $500,000 reduction for, that was one-time funding for families helping families. So where did that particular money come from? Was that federal money? Can someone tell me that? Or was that state general fund? Or
We've got the director of the DD Council here if you'd
great,
like to
great.
get that direct. Yep.
Hello, Representative Lyons. My name is Ebony Haven. I'm the interim executive director for the DD Council. The additional $500,000 was in state general funds.
So that was in the budget last year, and it was, what was it actually? Was it a program that it was being administered to, or?
So the additional $500 and all of our state general funds go to our Families Helping Family centers across the state. There are 10 centers, and the DD Council contracts with 9 of those centers.
So what was the funding used for, particularly? More specific, if you could.
So it ranges. Each center is different, and so they are basically trying to meet the needs of their particular community and region. And so just to name a few, some of them were able to do more outreaches in rural areas. Some of them were able to get more databases. to do more, I guess, to collect more data for their centers, and some of them were able to do state-of-the-art rooms, technology rooms to enhance their technology, to reach more of the families and the individuals with disabilities in their regions and their communities. I mean, we have one director here from Greater Baton Rouge, and so it just depends on what the needs are for that particular community.
And I ask that question because I know oftentimes when we fund things like that, the rural areas are some of the most impacted that's not here. And I'm not from a rural area, but I feel it. So I want to make sure that when we give monies like this, appropriate monies like this, and is used in these areas, it has an impact. And oftentimes we don't know when you pull money away that the results from that funding actually, positive results that we now go back to zero. So I just wanted to know it because it's totally gone. So I'm going to be trying to figure out a way to get it back. I think the impact of that is substantial to make that type of investment in it. So I wanted to ask you, particularly, what services or what the benefits were that we're going to be now losing, I guess, from that extra monies that was there. Well, one thing I'm going to ask you, Mr. Abraham, if y'all will look at that piece.
We will.
The Office of Disabilities is something that's really on my shoulder a lot of times, and I really want to make sure that we level the playing field as much as we can. And if we can look at that piece going forward, I really would appreciate it.
I appreciate that. Anecdotally, what I can tell you, just living my entire life and practicing medicine in the Delta, the poorest of the poor, those programs, they do have impact.
Yes.
They do make a difference. And sometimes the differences are what I would consider a soft difference. You may not really say, well, this did exactly that today, but life lessons, life skills, that particular individual moving forward from different grade levels, it does matter.
It does. Every little bit helps.
It does.
So thank you very much, and thank you for my question, Mr. Chairman, at the second bite.
All right, gentlemen, that's it. Board is clear.
Thank you.
Thank
Better
you.
leave now.
Thanks.